morning, everyone. Can you hear me? Good morning. Let me know if you can hear me. Okay. All right. And let me know if you're online. So send me good morning. Good morning. Good. Right. We thank God for a successful day. I think today is my first time meeting you guys. Okay. Right. So your leader gave me the topics you guys are following, and she gave me what I need to teach. Okay, so I will stay within my lane. Okay, I don't want any trouble. Yeah, so right. Let me open the slides quick so that we can start. Okay, I think for the next few hours we're gonna be online. Okay, so thank you so much. Thank you. Right. Okay, so let's start quick. Okay, let me share the screen so that we start. Perfect. Okay, right. So I'm not going to waste time. Let's start as soon as possible. Okay, share. Good. Right. So we are starting our town hall meeting. Okay. I've got these three topics. Okay. I learned every day you do two topics and one medicine or medication. Okay, right. So I think I will follow the pattern. Okay, right. So SIDH. Let's start quick. SIDH is a short form for syndrome of inappropriate antidiuretic hormone. Today, I'm not going to do a lot of in-depth physiology. I'm hitting on point because at this stage, if you are part of the ATT class, it means you have learned a lot. For all these 3 4 months, we have been learning all these Nclex stuffs. Okay. I mean, we should not go back to learning physiology. We are just hitting on the point. Then we solve questions. Then we are out of here. Okay. Right. If you meet on the main page, that is where we do more physiology because new guys have joined and a lot too are trying to catch up. But if your ATT is in and if you are part of this group, I believe you know what you are doing. So so physiology is not a problem for you. So everybody knows that syndrome or SIADH, okay, this occurs when the body releases too much antidiuretic hormone, even when not physiologically needed. Okay. The other name for antidiuretic hormone is vasopressin. Okay. The vasopressin. Yes. So let me get my stuff. This is the body, the human body. And this is what the kidneys. Okay. Anytime blood passes through the kidney, like this, okay, the kidneys will drain some water out of it. Okay. Yeah. So when the body or when the kidneys assess that no, I've drained a lot of water from the body, then I have to what? Absorb some, reabsorb some back into the bloodstream, these blood vessels. Then it goes back to the body. Okay. Yes. How is the kidneys able to do that? They are able to do that with the help of a hormone called vasopressin or antidiuresis, okay, hormone. Yeah. So there can be instances, this antidiuretic hormone, it takes its motivation or it takes its production, okay, from the brain, from the brain. So if you look at the brain, the pituitary gland, okay, is divided into two, the posterior and the anterior, okay. Yeah, so the pituitary gland helps us to get this hormone. It helps us to release this hormone, okay, the kidneys to release this hormone. And anytime this hormone, ADH, is released, what it does is that it causes what the renal tubules, okay, to reabsorb water back into the bloodstream. Let me tell you this thing. This is the bloodstream, okay. For the blood to be thicker, we have water or plasma, and we have solid or solutes, okay, or solutes. Some people also say particles, okay, right. Everybody knows water. When we take the particles, we have three major components that makes your blood thicker. If your blood becomes thicker, it cannot move well. It cannot move to major organs. So sometimes you'll be feeling dizziness. Why? Because your blood has become thicker and it cannot move more blood to what? To supply your eyes, your brain. Okay, when the blood becomes thicker. And what are the particles we are looking at? We are looking at glucose, sugar. That is number one. Okay, we are looking at sodium, number two. Then we are looking at BUN, blood urea nitrogen. Okay, there are other particles, but these three always take note. So when somebody gets hyperglycemia, okay, why are we rushing to give the person IV fluid? We are giving the person IV fluid a lot because we want to make the blood thinner. Then we give the insulin to shift the glucose back into the cells. Yes. Then we keep eyes on the potassium. When you have a lot of sodium, for the electrolyte guys, the sodium, plenty sodium, okay, or low sodium is going to cause issues for what? For the it's going to make the blood more thicker, okay. Then we have the blood urea and nitrogen that is also going to affect what the blood to be thicker or not, okay. Now let's go to, we have something we call osmolality. Lality. Osmolality is how concentrated the blood is. Okay, how concentrated the blood is against these three guys. Okay, osmolality. So we have osmolality, how concentrated a certain environment is. Okay, right. So if I go to the bloodstream, okay, we've seen that we have water. Everybody knows there's water, plasma, serum, whatever. Okay, then we have the particles, the solid, the gravels. The gravels. When you go to the beach, you see sand, gravels, and all those stuff. Okay, these are here the glucose, the major ones that can easily make your blood thick. Okay, is glucose, sodium, blood urea, nitrogen. Okay, now anytime you hear that osmolality, I've said that if you hear osmolality, think about concentration. Okay, when we say the concentration of the blood has increased, it means that what the number of solid particles have also increased. So when you go to the bloodstream, what are you looking at? You are looking at, is my glucose high? Is my sodium or other electrolytes high? Is my blood urea nitrogen high? That is it. That is something simple to understand. Okay. Yeah. So higher osmolality means what? Higher particles. Okay. Yes. So when that happens, we have something we call the specific gravity. The specific gravity. Okay. So yes, the osmolality is the mother language. But we come down specifically. What are the what gravity? What is the gravity? What is the osmolality deals with the concentration of the water and the particles, but the specific gravity will deal with what? Only the particles. What is the specific gravity in the bloodstream? So the higher the specific gravity, the higher what the particles, the solid. That's it. Okay, that's it. So these are the things you should know. These are the foundations that you guys should know. Once you get this foundation, you are done. Another thing I want to open your eyes on is what we have: the bloodstream, and we have urine. Urine. You cannot see urine if or whatever is in the urine is straightly coming from what? The bloodstream. Okay. Whatever is in urine is coming from the bloodstream. Okay. So if I have higher particles here, it means that when I urinate, I should be able to see higher particles in the urine. If I have plenty water in the blood, it means physiologically or homeostatically, I should see a lot of water in the urine. Okay. So what now happens? If I get any condition, let's say I have given antidiuretic hormone, and this antidiuretic hormone is to cause the water to go back to the bloodstream. It means that, let's say in the bloodstream here, okay, the particles or the solid are 40 grams, and the liquid here, the water, is also 40 mils. Okay, imagine they are the same, 40. Okay, now, and the urine too. Under normal circumstance, I should be able to get in the urine, the solid should be 40, and the liquid should be what? 40. Okay, to maintain equilibrium. But here's the case, I have a problem with this antidiuretic hormone. Something has happened that even if I don't need it, it is still producing. Is it the brain tumor? Is it a problem with the kidneys? Okay, or what? Where is it infection? Whatever, is it inflammation, systemic inflammations? Is it like SLE and all those stuffs? Okay, is it what is actually causing my ADH to be producing? It produces always when you get a problem with it, or sometimes it doesn't produce at all. Okay, right. So if this one gets a problem, and it is always producing, always producing. Remember, the ADH does not work on the bloodstream. They work on the renal tubules, these tubes. Okay, these tubes that will give you the urine. It works here. So instead of the urine, this 40 mils to come out, this ADH will now go and borrow 30 from here. So minus 30. So it will be left with what? It will be left with 10. And it will send the 30 back to the bloodstream. So over here, how much water do I have? 40 plus 30 is 70 mils. Okay, you understand the mathematics? Yeah. So because of the problem I have with this guy, I now have plenty water in the blood against the solid. I have not touched my solid. Oh. The solid is still 40. But I now have extra 30 mils added to the blood that has made the water gradient or the water coefficient to be higher. So when I come to my bloodstream, when I go to my blood, the water has gone up, and what? The solute is still the same. Okay, it's still the same. And when I go to my urine, you realize that the water part of the urine has gone low. Okay, and the solute is still the same, but because when we weigh them on the scale, you realize that the solute, the solid part, is the same, but it has gained more concentration. Okay, yes. So you realize that somebody with SIADH, the urine is always concentrated. But when you go to the bloodstream, okay, when I go to the bloodstream has a lot of water. Okay, and what? The solute is low. Now let's go and look at the major problems that we can get. Okay, if the water, if in the bloodstream the water is high and the solute is low, let's go back to our osmolality and our specific gravity. Osmolality talks about the gradient or the comparison of how concentrated the blood is. I have added water to the bloodstream. Will it be concentrated? No. So osmolality in the bloodstream will be low. How about the specific gravity? I have told you that the gravity measures only the solid. It does not compare with anything, only the solutes, the particles. And osmolality measures the particles against the water. Okay. Yes. So if the water has gone up and it's making the osmolality reduce in the bloodstream, what now happens to the solid? you realize that the water will start diluting. It will start diluting. It like you make gari and water. Okay, put sugar in the cup, add water to it. It will dissolve the it will dissolve the sugar. Okay, in the bloodstream, the sugar will be dissolved and the salt will be dissolved. Okay, so what now happened? Because we have plenty water in the bloodstream that has dissolved the sugar and the water, you realize that the solid concentration will also go low. So specific gravity will also reduce. Okay, yes. So if my sugar glucose is diluted, hallelujah, everybody likes the glucose to be diluted, but you keep eyes on it because the cells need the glucose in them to work, but the water has diluted it. Okay, the water has diluted it. So you'll be checking your blood glucose to know what is going on. Secondly, the salt, the sodium has also been diluted. Okay, so we get a condition called dilutional hyponatremia. If I don't spell it well, tell me. Hyponatremia. Nothing has happened to the salt content, but they have been dissolved. Okay, fetch that blood, go and put it on fire, heat it. You realize that all the water will evaporate and the sugar will the salt will crystallize again, and you have your normal salt. But because they have been dissolved in the water, we get a condition called dilutional hyponatremia. I told you that sodium is needed for what? Nervous coordination. Okay, nervous coordination. If there is one nerve here and there is another nerve here, how do they communicate? How do they talk to each other? They need sodium. Open the sodium potassium channels. Okay, so that the calcium can go into the sarcolemma. It can go to the cells and cause action potential so that they can connect with each other. If sodium does not start the journey, it won't work. So you realize that low sodium, where in the body, where can we find plenty nerves, is the brain. Okay, so you realize that because they can't talk to each other, the nerves cannot talk to each other, there's going to be slow in conduction. So the patient will be confused, agitated, okay, loss of consciousness, all these kind of unnecessary, okay, yes. So this is the basics, guys. Okay, I just wanted you to understand this. If you understand this concept like this, you are done. If you understand this concept, you are done. So always look at what? The osmolality, the specific gravity, okay, then the sodium level, the potassium, if you want to find, okay, SIADH. Then you look at your glucose level as well. But when you are doing osmolality and specific gravity, always look at what? The compare it with the hot urine and the blood. So the blood is what I just told you. So we have done the blood. Let's go to the urine. If I fetch a cup of urine, remember, ADH has come to take 30 mils of water from this urine. So I have only, for water, I have only 10 mils left. And for the solute, I have what? 40 grams. So the solute has become what? Plenty. Okay. Let's compare with osmolality. I told you that osmolality is a comparison between water and solid, the concentration. Okay. Yes. So over here, you realize that the solutes have gained more strength over the water in the urine. So osmolality in urine will go high. Meanwhile, in the bloodstream, osmolality was low. Okay. And let's look at what the specific gravity. That talks about only the particles, the solutes. Okay. So if solute in the urine has gone up, definitely specific gravity of urine will go up. So it will make your urine concentrated and be smelling. In adults, if you don't give them a lot of water and fluid, they will get what we call UTI. Some people will crystallize and you see a lot of debris. These white things in their urine, especially patients with what? Catheter, indwelling catheter. Like you need to flush the catheter. Yes. So now, so the specific gravity on the other side will also what? Go low. Okay. Yes. So let me just brush you. So knowing this, it means that when we take the slide, we are just going to brush to hit on point, answer some questions, then we are out of here. Okay, that's it. So, we know, hey, this is what I've done. Okay, right. Okay, so everybody knows that what SIADH is a syndrome. It's a syndrome, not one problem. Oh. It's ADH is causing a problem, and then it's causing so many problems in the body. That's why we call it a syndrome of inappropriate. It's not working well. Antidiuretic hormone secretion. Okay. Yeah. So this one occurs when your body releases too much ADH or vasopressin, even when the ADH is not physiologically needed. Okay, where is the problem coming from? It's a central problem. Okay, too much ADH coming from the brain will cause too much water to be retained in the blood. That water that came out of the blood through the kidneys, through the glomerulus, through the Bowman's capsule, through what? The ureters to your blood. How do you know? For you to get to ureter, it means it is already out of the body. Through the convoluted or the tubules, the proximal convoluted and distal tube. I mean, they will be reabsorbed back into the bloodstream. Okay, so they dilute, the blood now becomes diluted, and sodium is concentrated. Okay, right. So SIADH is primarily water problem that produces a sodium problem. Okay, so we already know the physiology. I don't have to go through. Okay, the primary target is all the kidneys collecting that. There is a receptor in the kidneys that binds this ADH will go and bind with it. We call the V2 or the vasopressin 2 receptors. This causes what? Aquaporin, all these technologies. You have aquapheresis, aquaresis, and all these one. It means water. Aqua, water. Oh, if you see this thing, don't let it confuse you. Okay, this causes insertion of water channels into what? The collecting duct. Water is then reabsorbed back into the urine, back from the urine into the bloodstream. So we get plenty blood. At the end of the day, a lot of water is sent back. Somebody can urinate like 4 5 liters a day. Sorry, they can maintain 4 5 liters, 6 liters, plenty water in their bloodstream. Okay, there's water retentions. Okay, so what now goes wrong in SIADH? Secretion continues despite low serum osmolality and adequate circulating volume. Okay, the kidneys therefore continue reabsorbing water, which I have taken you through. I don't have to go through all these ones. Okay, yes. So all this physiology we have talked about, you will see the dilution of the blood, the serum sodium will be diluted and the glucose will be diluted. There's going to be excess ADH. The kidneys will conserve water and bring them back to the stream. Okay, urine volume will go low. Okay, then the urine becomes concentrated. Hence, urine osmolality will go high and specific gravity will go high. Okay, this combination is extremely important for Nclex. Know this. If you know this physiology, any question that comes, you get it. Okay, so I have explained why the sodium will fall. It's not like the sodium, the normal sodium level. Yes, what is the normal sodium level? Send me in the chat box. Let me know. Yes, what is the normal sodium level in the body? The normal sodium level in the body. Yes, send me. Let me know the normal sodium level. Yes, I'm waiting for you. The normal sodium level. You should know your electrolytes. The normal sodium level. Yes. Okay. Yes. When we are doing participate, the more you participate, the more it sticks. Okay. Good. The brain was not created to pass exams. The brain was created to store emotional events. So when we are doing something and you take part, your brain will easily remind you that this day you said this, or this day is yes. Even if you don't want to, once you are online, participate. Okay, so 135 to 145. Okay, if you see your sodium level dropping sharply, one thing about this condition is that, especially patients who are on the ward, every morning we do this CBC-CMP, we call it the AM draws. So patients who are on the ward, patients who are in ICU, yesterday the sodium level was fine. Today, all of a sudden, sodium has dropped, bam, below normal levels. What is wrong with my ADH? Okay, what is going on? Was the So all these ones you should know. Okay, yeah. So sodium, example, somebody's sodium can drop from this level to this level. This is a severe hyponatremia issue. Okay. Why is sodium dangerous? Sodium needs the nerves in the brain, they need the sodium to conduct. Okay. Also, sodium, when sodium levels in the bloodstream goes low, eh, it is a gradient, it's a pull or push. Okay. There's going to be what? The danger aspect is going to be cerebral edema. Okay. The sodium that will hold the water in the bloodstream now is low. So the water has the freedom to go anywhere they want to go. They will now start seeping into the tissues. And the brain tissue is not unexempt. Okay. So when extracellular fluid becomes hypotonic, water moves into the cells. Remember osmosis. Yeah. So this is my bloodstream, and this is my brain. The sodium is here to keep the water and hold it. But the sodium, because everywhere sodium goes, water and chlorine follows. So if the sodium here goes low, Water now has the power here, so water can start seeping out. They go, they go, and they'll go and cause edema in the brain. Okay, that's where the problem comes from. So patients will now be having what? A hyponatremia will cause what? Extracellular fluid retention or hypotonic extracellular fluid. So water will now move into the cells and the brain will swell. So when the brain swells, we call it what? Cerebral edema. Okay. When the lungs has a lot of fluid under it or around it, we call it the pulmonary edema. That is it. So it's just a name change. Ehen. So when that happens, the patient will be now be having what? Central nervous system disturbances, neurological deterioration. If you are not careful with sodium low and water plenty moving into the brain, patient will be having what? Seizures. So this patient, you put them on what? Seizure precaution. Okay. If you don't treat the seizures, if you don't correct this neurological deficit, they can keep sinking, crashing, then they'll get coma. Okay, which I know you will not allow your patient to enter into the state of coma. Aha. When patient gets into coma, that should tell you that there is a possible what? Brain herniation. Okay. Or sometimes it can lead to a brain herniation or death. Okay, so neurological assessment is very important. Neurological assessment, your GCS, and your AFPU, or the extensive neurological assessment. Okay, extensive or in-depth neuro assessment. If you are in the ICU, you do this and you do this. If you are in the ER, you do this because you want to work fast and save a patient. You do this. Sometimes if you have time, you do GCS. But in ICU, you do the extensive one. Remember the ABCD. Okay. What causes SIADH? Why is it that antidiuretic hormone is secreting, even if you don't need it, it's still secreting? SIADH. What are some of the causes? The first place we are going to look at is the brain. Definitely, there can be a brain tumor, there can be a stroke, problems of the brain. Think about it. There can be traumatic brain injury. Somebody has used, the husband has used a wooden ladder to hit the head of the wife. Wham! Okay, there is a brain trauma, traumatic brain injury. Okay, yes, you can destroy the brain cells. Okay, and cause overproduction. If you are not lucky, you go and destroy the pituitary gland. Okay, brain tumor, meningitis, the covering of the brain, and the spinal cord. If it's infected, you are in trouble. Encephalitis, the brain itself, the tissues itself, the encephalon. Okay, if it becomes infected, what is causing the infection? Is it a viral infection? Is it a bacterial infection or what? Okay. Yes. Subarachnoid hemorrhage. Subarachnoid hemorrhage. You know the layers. So subarachnoid hemorrhage will be under the what? The meninges. Okay. Yes. Then the central nervous system infection. Is it only the brain or the spinal cord is now involved? Okay, good. We can talk about what? Small cell lung cancer. Yes, some lung cancers can metastasize. Remember, lung cancers, when the cancer is like a tumor, okay, we call it benign. When it start growing legs, we call it what? We call it metastasis. Okay, so don't let cancer start growing less. When it start growing less, you can't treat it. The patient will die with it. Okay. Yes. But when it's tumor like this, you can go and remove the tumor. Then you manage the patient. Okay. Or sometimes you can use radiotherapy to kill the cells. Okay. So it doesn't take long for lung cancer cells to travel to the brain from your chest to your head. It's not a long journey. Okay. The brain has a lot of oxygen and glucose. Cancer cells, what do they eat? Cancer cells don't eat carbohydrates. They don't eat carbon dioxide. Cancer cells need oxygen and glucose. That's it. So they always go to where there is plenty blood. And the closest from the lung is what? The brain. Okay, so small lung cancers, they can metastasize into the brain and cause issues there. Okay, right. So we have pulmonary disorders, pneumonia, tuberculosis, acute respiratory distress. Then we have positive pressure ventilation sometimes. We have some medications too that can cause disrupt. It's like drug interactions, drug and tissue interactions, all those ones. Okay. So these antipsychotics, cyclophosphamide, antipsychotics, chemotherapy medications, carbamazepine, CBZ, okay, os carbamazepine, SSRIs, all these ones affect what? Not always, but some patients, there have been research that some patients it affect their SIADH and cause hyponatremia in them. Okay, especially older adults who are beginning the course of SSRIs. You should keep eyes on them. Okay, so when you grow, stop overthinking. Okay, because if you get depression and we want to improve your mood, we will give you SSRI. Okay, you are 60 years, you are afraid to go on pension, you are depressed because you have not built your house. When they start putting you on this medication, if you are not careful and it affects your ADH, trouble has come. Okay, how will you know that a patient has ADH? When a patient is coming to the hospital, they will not come with their lab results, they will come with their signs and symptoms. And the hospital will do the investigations by the science and symptoms to diagnose. Okay, so clinical manifestations, there's going to be signs of what? Hyponatremia and cerebral edema. Example is what? Severe headache, nausea and vomiting, muscle cramps, weakness, fatigue. Okay, if sodium keeps falling, that's where the central nervous system will come in. Confusion, irritability, altered mental status, AMS, lethargy, and decreased level of consciousness. Okay, yes. So, so in severe cases, if you don't control this sodium that is falling, you think, sodium has fallen, so you don't keep eyes on it. You expect seizure in your patient, coma, respiratory compromise, and brain herniation. That's it. Okay. So you people said that 135 to 145 is very important. But remember, when sodium falls down, don't be in a rush to rapidly bring it back to this level. Okay. Don't be in a rush. Otherwise, you cause another problem. So the clinical picture depends not only on the number, but also on how rapidly the sodium fell. I mentioned this. I said that those in the ICU, those in the step down unit, PCU, and all those types, every morning, or those in the inpatient, every morning we have what we call the morning draws. That is what they do here. So your patient, if those of you who do night shift, because this is night shift, their job, every morning your patient, you take blood samples. You take blood samples to the lab to measure the CBC, full blood count, and what? The comprehensive blood count, CMP. Okay. Yes, comprehensive metabolic panel. So yesterday you did and sodium was normal within this range. Today You have taken your blood sample to the lab. When the results came, result is very low. Okay. Yeah. So if you, the night nurse, you are inquisitive, you want to know what is going on in your patient. Me, what I do is by 3 a.m., then I start drawing my patient blood to the lab. So kwata by 5:30, the results, or 5 a.m., the results will be up, will be back in the system, so I can look at what my full blood count. Is there any infection? Or I can look my about my CMPs. Is there any electrolyte problem? Is there any kidney issue? Is there any liver issue? Everything is fine. Okay, I know how to do my handover using my S bar. Okay, yeah. So a patient was this. He has rapidly fall from 140 to 120. Okay, yes. May be much more symptomatic than someone with chronic sodium of 125. Therefore, the rate of sodium decline matters in SIADH. Okay, let's look at fluid status in SIADH. A common misconception is that SIADH patients should look dramatically fluid overload. When we say SIADH, everybody is looking at fluid. Yes, you do your daily weight, but you can meet a patient like me. We can go and do laps and I have SIADH, but I don't have fluid overload. Okay. Sometimes we have something we call the euvolemic hyponatremia. Yes, the water level is yes, it has increased, but not super. So remember, I used the analogy, the 40 water, the 40 water, and the 40 solute. Okay. Yes. So sometimes, yes, water has been added. So sometimes I'll get like 45. It is still within the normal. But this little addition, it is not causing overload in me. Oh. I am not getting all this pulmonary edema, brain edema. I'm not getting it. You are not seeing it. But these 5 mils I added, it has diluted the sodium. So this condition, we call it the euvolemic EU. Normal fluid volume or blood volume. But this small what has caused what? Hyponatremia. So we call it, it's a compensatory mechanism where increase in sodium and water is excretion enough that obvious peripheral edema is generally absent. Okay. So in this case, this patient, if you have a patient like this, okay, a classic SIADH patient often has no severe dehydration, no major peripheral edema. He has hyponatremia and low serum osmolality. Yes, inappropriate concentrated urine. Okay, so you see all these things with this type of patients too, or with this classic, it's a syndrome. So we don't look at only one place, we look at different places. Okay, right. Laboratory investigations, you take your blood sample to the lab. What are you looking for? First, you look for your sodium. Okay, antidiuretic hormone is messing up. Why are we looking at sodium? Because more water in the bloodstream is going to dilute the sodium. We look at what the serum osmolality. Okay, forget about the ranges. Now we are doing NGN. NGN Nclex is going to always give us the lab value, the ranges. So what now if you are doing labs, you should understand that if I do sodium lab, what does it mean? If I do CBC, what does it mean? If I do this, what does it mean? The meaning of the lab and how to connect it to your clinical scenario or problem is the most, not the to chew the lab ranges. No, don't do that. Okay. So in SIADH, we know that serum will go low. Okay. Because there's too much water relative to solutes. In the urine, osmolality is going to what? Remain high. Sorry, yes, it's going to remain high. Okay, yes. So urine osmolality increase is relative to what will be what extracted. This is a major diagnostic clue. Urine specific gravity. So urine will be concentrated, simple. So a typically concentrated urine might be what? 0.0. What is the normal SG? Specific gravity. Yes, send me answers. What is the normal specific gravity? What is the normal specific gravity? Yes, the normal specific gravity. Yes, I'm listening. The normal specific gravity. Yes, I'm waiting for your answers. The normal specific gravity. You should know. Okay, so in the urine, 0.03 is a range. Give me the range. 0.003. Okay, so the normal specific gravity. Okay. So a typical concentrated value may be what? This. Okay. Always look at your specific gravities. This middle number here. When it start hitting 3 and above, 3 and above. Okay. That should tell you that what the urine is getting concentrated or the blood is getting concentrated. That is it. Okay. If you want to know that it's dilute, look at the last number here. If it is 2, okay, and below, it is 2 and below, then you should know that what it is what urine or blood is dilated. Okay. So urine sodium, what now happens to urine sodium? If I have a lot of blood, urine, water that has been taken from the urine, okay, the urine sodium will be what? Will sometimes be high. Okay, yes. The urine sodium is going to be greater than 30 despite hyponatremia in the blood. Okay, good. So these are the things you look at the diagnostic pattern to diagnose your normal renal function, no obvious edema. Okay. So SIADH, you are looking at what? Hypothermia, hyponatremia, inappropriate urine concentration, and clinical euvolemic patient. Okay. We have some other conditions that must be excluded. Differential diagnosis. Okay. Exclusion criteria. Exclusion criteria. So SIADH is not diagnosed simply because sodium is low. No. You have some conditions that can make your sodium also go low. So make sure that you rule out all those conditions and it will be left with the SIADH. So some of the conditions are what? Somebody is having hypovolemia, hypervolemic states such as heart failure. Patient does not have any heart failure. There is renal what? Dysfunction, adrenal insufficiency, hypothyroidism. You rule all those ones out to make sure that what there is no condition like this in the human body. Okay. and hyperglycemic related changes in measured sodium. Good. Now, as a nurse, you do assessment. So we are looking at what? Uh, you're looking at the neurological functions, the headaches, the confusion, lethargy, and all those ones. Intake and output is very key. Okay, and daily weight monitoring. So strict intake and output because ADH is retaining water. You monitor the oral fluids, the IV fluid, the urine output, and the overall fluid balance. Daily weight is very important. If patient can stand, sometimes you give them what? A scale to stand on. If they cannot stand, they are bed bound. Nowadays, most of the beds, it has a weighing scale in it. So you scale, but make sure that you take away the pillow because that weighing scale inside the bed is highly sensitive. Even paper, when you add paper to the bed, the weight will be added to it. So the bed sheet covering the patient, the blanket, is there any bag? Some patients will put their phone on the bed. Take all those things, their pillows, take it, put it outside the bed, weigh them, let them be only the patient and the you weigh. Okay. And before you put the patient, let's say you are getting admission, before you put the patient in the bed, you have to zero the bed. You zero the bed so that when you are doing the weight, you will not go and add the previous patient's weight to this new patient's weight. Okay. Remember, if you are managing SIADH and the following day they come and there are a lot of fluid, if you don't do your weight well, the doctor will be like, why is it that there's a sudden rise in weight? Water is weight. Okay. So they will now go and give lases. Meanwhile, it is the nurse who did not weigh the patient well. You cannot use one day in a space of 24 hours to gain 2 kg. It's crazy. 2 liters. Okay. Yes. So you are going to what? Do something about it. So weigh yourself. The seizure precautions is very important. So a low bed, all these triggers, take them out of the patient's room, okay? And the side rails, padded ones, and all those ones, okay? Neurological monitoring, emergency equipment, force precaution, rapid escalation for neurological or the D. Okay, I should come again on what? Which part? If you can specify it for me. Okay, so is it about the weight or what, Judy? Okay, so come again and I will explain to you. Treatment of SIADH. We have you treat the cause, the severity, the symptoms. Okay, you treat based on the treatment. That is how your treatment should go. Okay, the duration of the hyponatremia and the volume status. So you treat the underlying cause. If you identify it, you reduce excess free water. So fluid restriction is very important. Okay, remember ice chips, ice blocks is also part of fluid. Some patients will be like, they said that I'm on fluid restriction, 1,000 or 1,005 a day. Okay. But small time they will be calling you, please, can I get ice? Can I get ice? Yes. When you come here, you realize that people chew ice block like they are chewing biscuits. Okay. So safely increase sodium serum level when indicated and prevent neurologic complications. Fluid restriction is very key. Like I've said, this is a central problem. Okay, so you have to put patient on fluid restriction. Okay, so sometimes we look at 800 to 1,000 ml a day within 24. hours. Yes, so I was saying with the weight, Judy, I was saying that before you put the patient in the bed, let's say you are getting admission from OPD, you have prepared this bed for this patient. Weigh the bed. We call when you weigh the bed, we call it zeroing. Okay, zero or zeroing. When you zero the bed, it means that the old patient that was lying on it, okay, you have taken away all the data, everything, the previous weight. What this bed, this weighing bed is very sensitive. Sometimes some of your colleagues will even go and sit on the bed. They'll be chatting in the patient's room. So before you admit the patient, put the weigh, zero it. We have a column, we have a button there called zero. Now, when you put the patient in bed, the first day you weigh them, like that very moment you put them in bed, weigh them, let this bed capture this new patient's weight. Okay, so that's the first weight. Let's say 70 kg. So tomorrow morning, we do weight every morning. Night nurses do it. So tomorrow morning, the night nurse doing his morning care will still weigh the patient. When they weigh, the bed will advise you that there is abnormal difference. There's this is difference. There's okay, yes. So that's what you should know. Okay, yeah. So let's say if you don't take away the pillows, the bed sheet, and all these ones, some people will put their bag, especially the females, they put their bag and handbag on it. So all these stuffs, if you don't take it out of the bed, it will be added to the weight. So let's say a female was having a handbag. You know females and their handbag, big one, cosmetic, everything is in. They call it 24 hours. Everything is in the handbag. So if you don't take the bag and you weigh the patient on the bed, okay, they you can get like say if this one give like 4 kg, you can get like 74 kg. Okay, meanwhile you've weighed the bag. In the morning, the doctor coming for rounds will see the new weight and think that it is fluid accumulation. So they order for laces. And that laces, if you give it, it is going to cause severe blood pressure drop. Okay, so that is what is. Jennifer is laughing at me. Okay, yeah. So these are the things you should know. Fluid restriction is very important. Okay, if patient is allowed 1,000 ml, you should know what they are taking. Measure it. So all these things, people think gelatin and ice is not. It is fluid. Okay, good. Manage test. These patients will be complaining of tests. Fluid restriction can be uncomfortable. The mere fact that we told you that your fluid will be low, you are going to reduce fluid. You'll be having that dry mouth and all those things. Yes. So, frequent oral care if patient is unconscious. Sometimes some small ice chips to keep their lips and their mouth a bit wet. Okay, good. Then hypertonic saline. Okay, how do I increase the sodium in the bloodstream back to pull the water from the brain, to pull the water into the bloodstream? I have to give hypertonic solution, hypertonia. So sometimes 3% sodium chloride IV fluid you give. Okay, yes, especially if patient is having severe hyponatremic symptoms. You give seizure, confusion, and all those stuffs. You give. Okay. But the major concern, which I've already said, that's what correcting sodium too quickly. Sodium hyponatremia itself causes what? cerebral edema. So if you want to rapidly take it out of the brain tissues into the blood, you now cause an issue with the myelin shield. We call the osmotic demyelination syndrome. This is the cells of the brain, the nerves, okay, like this. The myelin shield covers it like this. That fluid that entered, some are accumulating here, plenty fluid here. So if I give sodium and I give it in a rapid way, and I want to increase, if your concentration is only about the blood, you want to increase sodium concentration in the blood, there's going to be a rapid movement of water from this myelin shield to this. So you shrink it quickly. We call it demyelination syndrome, or the pontine myelinolysis. Okay, yes. So don't, if somebody comes with a sodium of 110, don't think that within 24 hours or within this, you want to quickly bring it to 140. No, you cause issues. Okay. Then medications. Which medication can we give in situations where your antidiuretic hormone is overly producing, that you don't know what to do about it? You give these two brothers. We call the term the Vaptans. So we have the Tolvaptan and the Conivaptans. Okay. So this one does, it's make sure that free water is removed. Okay, it's removed out of the body. So that water that the ADH was sending to the bloodstream, these guys will collect it. That, hey, where are you taking it to? Go take it back to the urine, let the patient urinate. So if you take this medication, the other problem with this medication too is that it will also cause dehydration. So these medications will suppress the ADH. Okay. Yeah, so we will go into it. Okay, this one is our topic for today. Okay. Yeah, so the Tolvaptan and all those ones. Okay. Then you treat the underlying cause, which I've said. So if there is a cancer, lung cancer, treat the malignancy. If there is CNS infection, treat it. If there is any pulmonary disease, treat it. Okay. So what should the nurse not do? What should the nurse not do? If sodium is 116 in a known SIADH, what is your concern? Okay. The nurse should not encourage the patient to drink large amount of water. Okay. Otherwise, you cause circulatory overload. Okay. Yeah. So we have the SIADH and diabetes insipidus. When you get the slide, you go through, because diabetes insipidus is the opposite of what SIADH. Okay. Yeah. So these are all scenarios for scenarios to go through, which we have already talked about: dilutional hypotonic plasma and all these ones. Okay. Now let's look at this clinical judgment scenario. A 66-year-old patient with small lung cancer becomes increasingly confused. You did assessment, blood pressure was okay, heart rate is fine, respiratory is fine, saturation is fine. The nurse doesn't know what to do because all the blood pressure vital signs are cool. If your vital signs are okay, the next thing you should go is your labs. That is how to catch symptoms. Vital signs are fine. The next one to go is the labs. If the labs are okay, the next one to go is the imagings or the scans. That is how we do it. Okay. Yeah. So vital signs are okay. The nurse will be like, mommy, you are okay. Everything is fine. So what is your worry now? Go and sleep. No. Go to the labs. You went to the labs and saw that sodium has dropped to 117. Osmolality is 528. Urine osmolality is also gone up. Okay. Urine specific gravity, 3. Even there is a 2 after it. Severe concentration. Urine output has decreased. This one is affecting the kidneys. Glomerular filtration. Okay, so once you see that there is a glomerular filtration reduction, what is causing the glomerulus not release a lot of fluid? Is it that we are not getting more blood to the kidneys, or the glomerulus is dying? That is another story for another day. So recognizing Q, this is a critical thinking question. You get it in Nclex. Okay, I have more questions for you. So recognizing cues, the important finding. You saw the lung cancer, so you are adding everything. Then you make your judgment. Okay, recognizing cues. So we have the severe hyponatremia was in the scenario. Serum osmolality is low, urine concentration is high, there is a neurological change, and there is reduced urine volume. So you have recognized the cue. Let's analyze the cue. If you analyze, combine all these ones, okay, what do you think? Yes. So this analyzing cues will help you to know that, oh, it is not a heart failure. It is not this. It is not that. It is this condition. Okay. So SIADH, you prioritize your hypothesis, which we have done it last week. Okay. So your immediate concern is what? The acute neurological deterioration from what? Hyponatremia. Sometimes the diagnosis is no more important. US here, they are no more particular about the diagnosis. They are more particular about this signs and symptoms and the vital signs you've gotten. Which one will you treat first? That is what we are prioritizing hypothesis. Your immediate concern is what? This acute neurological deterioration from hyponatremia. If I correct this one will be fine. The other ones will follow. Okay. Then you take your action. Notify the provider, you, the nurse, is not within your scope to prescribe medication. You did your vital signs here. Everything was fine. Okay. Notify provider. Institute appropriate seizure precaution. The nurse, is your duty to do it. Okay. Frequent neurological assessment is very important. Strict eye and nose. You follow the prescribed restrictions, fluid restriction. Then you prepare to, or you administer prescribed hypertonic saline when indicated. Then you closely monitor the patient. That is it. Okay. Let's look at another scenario over here. A patient with SIADH has a sodium of 125. We know sodium is 135 and above. Okay, which new findings require the most immediate action? Which new findings require the most immediate action? So the answer here is D, new seizure activity. Yes, the central nervous system is getting involved. Okay, we saw this. Why? Because in rapid response, we learned that you do your A, B, C, D. Okay, A, B, C, D. Okay, so the D, deterioration. Do you find any A problem here? No. This sometimes that is what you should do, and always, not even sometimes. Do you see any B problem here? Breathing problem? No. Do you see circulation problem here? No. So the next is deterioration, disability, deterioration, GCS, and the AFPU. Yes, I am seeing a neurological what, a seizure activity here. So that is my answer. Okay. So when you get when you get a slide, then It says, what if the patient has sodium of 118 but no symptoms? Asymptomatic hyponatremia. Yes. Do not automatically assume that every patient with sodium low receives rapid 3% saline correction. No. Treatment depends on the symptom, acute versus chronic, etiology, other clinical factors. That is why you recognize your cue, you analyze it, you prioritize your hypothesis, and you treat it alongside. Okay, good. So that is about SIADH. Let us do HHS. HHS, the hyperosmolar hyperglycemic state. It's a state. Eh? It is a state, okay, that every human being can enter in this world. Every human being you see, me, you, your child, your husband, it is a state that you enter. HHS. And when you enter this state, this is a state of what? It means your life is threatened. It's either you are coming back to life or you are progressing to death. That is why we say this is a life-threatening hyperglycemia emergency, most commonly associated with what? Type 2 diabetes. Okay, type 2 diabetes, hyperosmolar and hyperglycemic state. Okay, so extreme high blood glucose plus profound dehydration plus high serum osmolality. So now you know osmolality. If somebody has come to the hospital with very high blood glucose, I told you that three things make your blood thick. So the fact that the person's blood sugar is high, on the other side, the blood is also becoming thick. Yeah. Okay. So extreme high blood glucose and extreme what? Hyperosmolality. Okay. This will trigger what? Diuresis because of the sugar. So the patient will what? The little fluid left, the patient you urinate it away, and there's going to be dehydration. Yes, it can go as low as your brain will start shrinking. You start having altered mental status. Okay, some people they have trace in ketosis. Okay, that should tell you that the cells, the cellular level, have started getting what? As acidosis. Okay, so you are building ketosis a little, but in HHS, the ketones will not be high as what? DKA. So people will get what? Trace. I should tell you that what? The cellular level, they are not getting blood, they are not getting glucose and oxygen. Okay, so they are depending on other sources for energy. Yes. So the core problem is insulin. When insulin is produced, but there is a patient has insufficient effective insulin. Yes. So insulin has been produced 10 units or 70 units. Insulin is in the bloodstream. Insulin must work so that glucose and potassium will go to the cell. Let's put potassium aside. Insulin, everybody is looking up to insulin. Insulin work, oh, insulin said, I can't work. And the sugar will be building. Okay, building. And you end up what? Getting what? High blood sugar. Okay, so relative insulin deficiency plus increased counter-regulatory hormones will cause what? Glucose cannot be adequately utilized. They are stored Okay. When glucose are stored in the blood, they can go to the liver. The liver will produce its own glucose, and use it. Okay. And the addition, it will bring it back to the blood. So you'll be getting high power. Some people will cross 600 grams of glucose. Okay. Yes. So when there is hyperglycemia, this glucose will start spilling into the urine, cause osmotic diuresis. You urinate the little water in the blood, and there will be dehydration on top of the concentration. Okay, so there is massive water and electrolyte loss because the patient is urinating polyuria, severe dehydration, serum becomes increasingly concentrated, osmolality goes high. So there is hyper serum osmolality, okay, and brain dysfunction. So you see what confusion, seizure, and coma. Anytime you see these signs, and you know that the brain is involved. Okay, so we have heard what happens in HHS. So you know that insulin is ineffective. At the same time, stress hormones. Because why is it that the glucose is stuck in the blood? They are not going to the cells. This is a stress to the body. Homeostasis or homeostasis is affected. Okay, glucose is stuck. Insulin too, you are here. Open the channels to glucose to go. You say you are not working. I mean, okay. So the liver eh, will now go to the glucagon. Okay, convert it towards glucose. They will take when they convert the glucose, the body does not need plenty glucose. It's like a child who is crying for food. You give them food, they ate only little one, then they kept the rest somewhere. That is what happens. So the liver will bring the glucose from the glucagon. Okay. Then they will take the small amount, give it to the cell. The cells are okay. The rest goes to the blood. So glucose here, new glucose is coming. The catecholamines from the kidneys. Okay. The catecholamines, adrenaline and the noradrenaline stress has come. Why? Because the blood has become so concentrated with glucose that it is not moving. It is not moving. It is not moving. It is not moving. So you realize that the kidneys will be struggling. Somebody is having, the eyes are getting blind, retinal hyper or hypoperfusion. Brain is not getting a lot of blood because the blood has become thick with plenty glucose in it. Okay, yes. So the catecholamines will be released to increase the blood pressure, squeeze it so that, I mean, okay. Then we have the cortisols, all the steroids, stress hormones, growth hormones are released. Okay, yes. So these hormones increase hepatic glucose production and oppose insulin. Okay, this one causes more, steroid, these cortisols, they will come and oppose insulin. So they will cause those people who use a lot of steroids, majority end up getting hyperglycemia because it's anytime you take steroids, eh, it holds the insulin in the blood. So the insulin cannot push the glucose to the cells. Okay. So you see one problem that we got to. Now they have connected problems. So the hyperglycemia will go high. Some people will go as high as over 600 milligrams per deciliter. Okay. So why does the patient become so dehydrated? When blood glucose becomes extremely high, the kidneys cannot reabsorb all the filtered glucose. So what now happens? Glucose will now enter. the urine. So we get what we call glycosuria. Yes. In Ghana, people will say, I was urinating and I tested my urine. A lot of sugar in it. Okay, yes. So this produces what osmotic diuresis. Glucose pools into the urine, and there is what hyperglycemia, glycosuria, osmotic diuresis, profound dehydration in the blood and in the cells. So this is a visual cycle. We've done this one, so I don't have to go through again. Okay. Then we know why that the serum osmolality increases. I've told you that. It tells you how concentrated the blood is. So HHS produces major water loss and severe hyperglycemia. Therefore, serum becomes hyperosmolar. Okay, so you see more sugar, the sugar aspect. SIADH, our problem was the sodium. But HHS, our problem is the sugar. It is increasing the concentration, making the blood more thicker. So still you need your IV fluids. Okay. Yes. Why does this one affect the brain? HHS affect the brain. The brain is particularly sensitive to major changes in osmolality. So if the serum solute or osmolality rises, water will shift out of the cells. Okay, just like the SIDH. So neuronal function becomes impaired. Then we will see all these what weakness, confusion, lethargy, seizures, and coma. Okay, which patients are mostly affected? Type 2 diabetics. Type 2 diabetics. Some DKA patients also sometimes experience that, but mostly type 2 diabetes. Okay, good. So patient with known type 2, previously undiagnosed diabetes. Okay, yes. So please, your glycated hemoglobin, HbA1c, keep eyes on it. Because you don't know, you may be building sugar, but you don't know what is going on. Okay. Limited, some people don't drink a lot of fluid. So always their blood is thick. Okay. When they urinate, it is very smelly, very concentrated. We drink a lot of water, at least 2 liters to 3 liters a day. Okay. Acute illnesses and medication related what hyperglycemia, like taking steroids and all those stuffs. So the common triggers we are looking at is what infection, like example pneumonia and all those stuffs. Okay. We have the insulin, insufficient insulin, the eyes, we call it the eyes of hyperglycemia, the infarction, okay, and what the illnesses. So myocardial infarction, stroke, pancreatitis, okay, surgery, stress hormone, stroke, okay, blood is not moving, blood is thicker, all this one, trauma, medication not adherence, newly diagnosed diabetics. Okay, yes. So certain medications can contribute to HHS, like the steroids, the diuretics, some atypical antipsychotics, and other drugs that worsen glycemic control. Okay. HHS develops over days to weeks. It develops slowly. That's why I was saying that you can be developing HHS, but you don't know. You only start showing signs and symptoms when it becomes severe. That is it. So early clinical manifestation is the P's: polyuria, polydipsia, weakness, weight loss. You wake up in the morning, you are feeling dizzy, and all those ones. Late signs: dry mucous membrane, poor skin, tachycardia, weakness, hypotension, orthostatic hypotension, confusion, lethargy, visual disturbances, and all those ones. Okay, so the key point is early HHS is polyuria and late is low urine output. Okay, good. Let's look at the laboratory findings. Yes, sugar can never hide. It is always going to be super high. Your ketones can be mild or zero. Yes. Then we have the pH is going to drop. Remember, because we are not getting enough glucose and blood perfusion to the cells. So acidosis. That is why sometimes you get some little ketones, mild ketones. Acidosis is building in the cells. Bicarbonate is going to be low. Okay. The anion gap is usually absent or mild because we don't have severe like DKA that the ketones is going to be high. The acidosis is all over the moon. Okay, that the anion gap will be so wide. This one, the anion gap sometimes is closed. The BN and creatinine often elevated from the dehydration, the serum concentration, because water is lost. Okay, yes. So this is, I mean, it's not ketone problem. Okay, so we don't have to go through this one. Yeah. So the difference between HHS and DKA, in DKA there is no production of insulin, not enough. Okay. Yes. So that is what you should know. When you get a slide, we have the comparison here for you to go through. Okay. Yes. Then why is it that there is no Kushma respiration? Kushma respiration are compensatory response to metabolic acidosis. That ketone must get out of the body. So the body must what? Breathe it out. But here we don't have issues with ketones. There is no profound ketoacidosis. So what are we going to breathe out? Patient will be fine. Okay. Yeah. So, and potassium is one of the most important concepts because the insulin is sitting in the blood. They are not opening the channels. Okay. They are not opening the channels. Okay. And potassium is stacked. Okay. Let me show you. This is the bloodstream. When you come to the bloodstream, we have potassium here. We have sodium, we have glucose here, and we have insulin. Insulin has been released by pancreas. Insulin has finally arrived. Okay, yes. So insulin, come and open this door and let potassium and glucose go out. Insulin said, no, I won't open. So these two guys are stuck here. Okay, when the glucose build up and the blood takes the blood vessels take this hyperglycemic blood to the kidneys. The kidneys will trigger what we call diuresis, osmotic diuresis. So the patient will urinate the water parts out. And that water, the plasma, or the serum, is full of electrolytes. So you end up urinating a lot of electrolyte out. Okay. Yes. Sometimes, if you are lucky, we have patients who swing. Sometimes potassium will be normal, sometimes low, sometimes high. In the initial stages, sometimes before the diuresis will set in, potassium is high because potassium is not moving. But when the diuresis starts setting in, that a human being is urinating 5 liters a day, 6 liters a day, 4 liters a day. Osmotic diuresis, you are going to waste all the potassium in the bloodstream. So they end up getting low serum potassium. So you now have another trouble on top of the troubles you have. Okay. Yes. Okay. So that is, you said I should scroll up a bit. You said I should scroll up a bit. Okay. So this is what we this is the major thing. I've touched on all the major ones. Okay. I've touched on all the major ones. So your fluid, electrolyte replacement, insulin, and you treat the causes. Okay, good. So these are the things I want you to take note. Okay. All the rest I just add up. I don't have to go through all the rest. I just add up. I've talked about it already. So all the rest are add ups. Okay. All the rest are add ups that you should know. Okay. Yeah. I don't have to go through all of them. We are not here to waste time. All the rest are add ups. Okay. Now let's go to our medication. So the medication, I'll hit on 1 or 2 or 3 points. Then, so the Tolvaptan, some call it the Samska, and the Janica. Okay, this is a vasopressin antagonist. I told you that they suppress antidiuretic hormone. Okay, they bind to the V2 receptor. Okay, and prevent water from being lost and from being sent back to the bloodstream. Okay. We use it to treat what? Hyponatremia, dilutional hyponatremia, especially in SIADH, heart failures, and all those stuffs. Okay. Yes, some people also have some autosomal dominant polycystic kidney disease. You can also use this medication to treat. This one helps to improve slowed kidney function in decline in adult at risk of rapidly progressing this disease. Okay. Yes, it's a route of administration is the MAF. I mean, Nclex will never ask you this. The dosage is mostly 15 milligrams per ounce once daily. Okay. Some people can go 30 milligrams, some even go highest to 60, depending on what their physiologic demands. Okay. Right. Then, because it is preventing fluid retention. You urinate a lot, so you should. It is not a diuresis. Okay, it's not a diuretics. Okay, yeah, but your hydration is very important when you take this medication. The common side effects we are looking at is what? The polydipsia, the polyuria, the nocturia, and the dry mouth. Okay, these are the major effects. Then the serious adverse effect and concerns. This one can cause rapid correction of what? Sodium. Okay, yes, true. If sodium is seriously corrected rapidly, I've told you that you cause the demyelination syndrome. Okay, so you'll be having this nervous system signs and symptoms like this atrial dysphagia, altered mental status, quadriparesis, seizures, and coma. Okay, so this is what. Then hepatotoxicity. This one can cause severe what? Liver injury. So you don't give it to a patient who is having liver problems, like paracetamol, because liver metabolizes the medication and the kidneys excrete it. Okay, yes. If kidneys cannot excrete, you give it to the intestines, the large intestines. Okay. So if somebody has liver problem, you always mostly advise to omit. Okay, because it can cause a fatal liver injury and acute liver failure. So when somebody is taking this medication who doesn't have any liver issues, monitor what their liver enzymes. Very important. The ALT, the AST, and the bile, the bilirubin. Okay. So, and dehydration will cause what? Tolvaptan will cause polyuria, water loss, and all those types. So you watch for hypotension, tachycardia, dizziness, your blood pressure, and also vital signs, weight loss. You check for it. It can cause hypernatremia. Now the reverse becomes the problem. Okay. So now you have removed the water out of the body. Okay. So the solute, the sodium is going to be high as in the SIADH. Okay. So a patient receiving long-term Janica should have access to water and should be able to respond appropriately to tests. The major interactions, this medication is metabolized by what? This liver enzyme. Okay, so these drugs can substantially increase the concentration, increasing toxicity. Okay, so uh, some of the interactions are ketoconazole, ordazole, clarithromycin, this HIV medication, antiviral medication. Okay, yes. So when you are taking them, be careful. Then we have the inducers. This one reduces the effectiveness of these medications: rifampicin, carbamazepine, phenytoin, and St. John's wort. So you should avoid it generally. Okay. Then this combination should be avoided generally. We also have the grapefruit. You should avoid it. It can inhibit intestinal enzymes and increase what? Exposure to what? Tolvaptan. Okay. Desmond is pressing me. Desmopressin. Yes. So this is an interesting pharmacological interaction. Desmopressin is what? A V2 receptor agonist. It's a vasopressin agonist. They are friends. Okay. So when you take tolvaptan, tolvaptan will come and counteract this guy. Therefore, tolvaptan can interfere with V2 mediated action of what? Desmopressin. Concomitant use or using hand to hand usually generally should be what? Avoided. You cannot use this medication and use this medication. It means you are taking this medication to suppress, and you are taking this medication to counteract. No, you are not going anywhere. You come back to zero. Okay, so that is what you should know. Okay, so our major concern is what? The hypovolemia. Don't finish all the urine, the fluid in your body. Take note the osmolalities and all the electrolyte imbalances. The anuria is also a concern. Okay, yeah. So these are the things. How should the nurse monitor? For a patient receiving this medication, think about your sodium, water, fluid volume, and your liver. So your serum sodium is very important. Strict intake and output. Okay, right. So guys, this is the end of today. All these ones are additions. When you get the slide, the root and all those ones. Okay, they are additions. So when you get the slide, then you you manage it. Okay. Let's try our hands on some questions. Then we say goodbye. Okay. So this is a clinical judgment question. Question number one. Question number one. Try your hands on it. Sharp. Question number one. Try your hands on it. Yes. Let me know the answer. There we go. A 69-year-old patient with small cell lung cancer becomes increasingly confused. Assessment finding shows blood pressure is this, heart rate is this, no peripheral edema, and urine output is 350 over 8 hours. Laboratory results are sodium is 117, osmolality is 258, urine osmolality is 620, specific gravity is 31. Okay. What physiological process best explains these findings? Yes. Yes. Oil in my hand. More answers. More answers. More answers. Try your hands on it. More answers. Get involved though. Try your hands. Okay, so the answer is B. Inappropriate ADH activity causing free water retention and dilutional hyponatremia. Okay, question number two. The nurse is caring for 4 patients. Which patient should the nurse assess first? So you've got all these 4 patients. Sharp. Question number two. Question number two. So you write the answer. You write the question number, then the answer beside. Yes. I need more answers. Everybody should participate. Everybody should participate. Quick, 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 quick. Then we are done. Okay. Which patient should we assess first? Okay. Okay, so the C stands out. Okay, patient with SIDA, sodium is low, who has developed new muscle twitching and confusion. Okay, it stands out. Question number 3, sharp. A patient with SIDH has a serum sodium of 114. Which new finding most strongly indicate progression to a life-threatening complication or state? Question number 3. Which new finding most strongly indicates progression to a life-threatening complication? Question number 3. Okay. A generalized tonic clonic seizure. Okay, cool. Number 4. A patient with SIADH has low serum osmolality but markedly elevated urine osmolality. Which explanation by the nurse is most accurate? Number 4. Serum osmolality is low but high urine osmolality. Number 4. Which explanation by the nurse is most accurate? Number 4. I need answers on number 4. Yes. Are we there? Give me answers on number 4. Number 4. Yes. Number 4. Yes. I like your answers. That's nice. Okay. Good. Right. So we've got what B. ADH is causing the kidneys to continue conserving water despite already diluted blood. Okay. Number 5. Select all that apply. Which findings are consistent with SIADH? Number 5. Which findings are consistent with SIADH? Yes. Number 5. Select order apply. Which of the findings below? Syndrome of inappropriate antidiuretic hormone. Number 5. Select order apply. Select order apply. Okay. So yeah, we've got sodium 118, that is low. Osmolality, serum osmolality 260. Okay. So this I'm saying soaked inside. Yeah. So concentration is low. Okay, it's below the 300s. Then the urine concentration is super high. Okay, then urine specific gravity soak inside. Yes, above 3. So urine is concentrated. Urine output 6,000 mils. No, this one is diabetes insipidus. And F is increasing confusion. Okay. F is increasing confusion. Okay. Yeah. Okay. Yeah. Right. So number 6, shoot. A patient with bacterial meningitis. Let me see. Oh yeah, Genevieve. Yeah. So yeah, the serum, normal serum and urine osmolar. Me, I always look at 300. Okay. Yeah, the concentration should be higher. If it's higher than 300, it means that it is. So always me, that is what I use. Okay. So if you realized, when we finish the question 6, I will explain to you. That is what I always use, 300 as my mark. Okay, yeah. So a patient with bacterial meningitis develops sodium 120 milliequilibriums per liter, decreased serum osmolality, and concentrated urine. Which complication of the underlying disease should the nurse suspect? Yes. Shoot. Question number 4. 6. Question number 6. Shoot your answers and let's go. Let's be fast and leave the line. Let's be fast and leave. Yes, question number 6. Question number 6. Yes. Everybody should participate. Oh. We are a lot on the line. Everybody should participate. Send me your answer. Okay. Right. So the answer is SIADH. Cool. Question number 7. The nurse reviews prescription for a patient with SIADH and sodium is 118. Which prescription requires the most immediate clarification? Number 7. Which prescription requires the most immediate clarification? Number 7. Number 7. Number 7. Oh, let's be faster. This one, the answers are just glare. Yes. You should not waste. You should not spend much time on these questions. They are cheap. Yes. Number 7. Okay. 7 is C. Okay. Number 8, a patient with chronic SIADH has been receiving treatment. Which laboratory trend should concern the nurse most? Which laboratory trend should concern the nurse most? With chronic SIADH has been receiving trend. Which laboratory trend should concern the nurse most? Number 8. Yes. Question number 8. Okay. Question number 8. The answer is B. Okay. Right. So, question number 9. A nurse is teaching students about the neurological manifestation of SIADH. Which sequence best explains the development of seizures? Number 9. Yes, can cause osmotic demyelination syndrome. It's true. Yes, good. Question number 9. Good. Question number 9 is B. Okay. Hyponatremia, decreased extracellular osmolality, water enters the brain, cerebral edema, and seizure occurs. Okay. Right. Question number 10. A patient has 119 sodium, serum osmolality of 262, urine specific gravity 29, and no peripheral edema. Which additional finding will most strongly support SIADH? Question number 10. Question number 10. Question number 10. Question number 10. Okay, so question number 10 is C. Okay, so it's not B. B, when you say urine output, it's different from urine concentration. Okay, you can have a normal output, but there are a lot of solute in it cause concentration. Okay, so in SIADH, they don't have a problem with glomerular filtration. They don't have a problem with glomerular filtration. So they filter urine all right, but the urine is concentrated because when the urine, when they filter the urine and the urine is coming out, the collecting duct will, there will be reabsorption at the collecting duct and the tubules back into the bloodstream. So they end up what? Getting concentrated urine. Okay. Yeah. So the answer is C. Okay. Right. And I think we should end here. Then maybe in the evening we continue with the rest of the questions. Okay. Because we have been online for long. So I don't want to waste your time. Today is Saturday. People are doing so many things. So evening time, I'll leave the questions on. Evening time, we will meet and finish. There are more questions here for you guys. Okay. There are more questions for you to solve. So until Nicholas comes back, we I'll be taking you through. So he comes back, then he take over. So please, evening time, let's meet and solve questions as well. Okay. Evening is solely questions. No studies, nothing. Evening is solely questions. So please, okay. Because of that, this weekend I'm hosting you guys. Okay. I wanted to host the main class, but this evening now, this weekend, let me host you guys so that from Monday we start the main page. So I will announce it on the main page. Your normal time for meeting in the evening. Okay. Your normal time in the evening. Okay. Right. So please, evening time. Make sure you come. Prepare yourself. It's going to be only 2 hours in the evening. Okay. So make sure you are present. Thank you so much. Okay. Bye bye for now. Goodbye for now. Okay. Yes. God bless you too.